Hello, welcome to the short where we are talking Esmolol, the ultra-fast acting beta blocker that we're going to be using for our cardiac arrest patient in refractory VFib or VTAC. Before we dive into it, let's kind of define what that means. Okay, in this context, refractory VFib or VTAC is the patient who is not responding to the traditional approaches that we use to address those things. And so in our standing orders, what this is going to be is 3 defibrillation attempts, 3 rounds of epi, and 450 milligrams of amiodarone. At that point in the resuscitation algorithm, you're going to go ahead and I'm looking at my Esmolol. Okay, what is an Esmolol? Again, we said it's an ultra-fast acting beta blocker, and by ultra-fast acting, it is very fast acting. Within 90 seconds, this will start to take effect. So you can expect it to start impacting your patient very promptly, within a minute and a half or so. Half-life is around 9 minutes. So this is important because we're going to talk about compounding effects of medications in a second here, but the risk of this having compounding or stacking effects, if this is given more than one time, are very low because the effects are going to taper off fairly quickly, okay? So within 9 minutes. What this is going to do, it is a beta blocker, so it is going to have beta blocker effects. It's going to specifically target the beta 1 receptors. And so what that is going to do is reduce heart rate, reduce cardiac contractility, or how hard the heart is contracting, oxygen demand, AV node conduction, and as a byproduct of these things, this is going to increase the conversion rate with our defibrillation. Now, again, this is kind of a two-prong effect here. What we're doing when we're giving Esmolol is we're trying to try a different approach, okay? If we continue the same thing and we just keep going, but we're not getting any type of result, if we continue to go down that path, we're likely going to continue to not get a result. So Esmolol is kind of an answer with that in mind, okay? So we've been giving epi to our patient. Currently, we operate in a very epi-driven resuscitation model, right, wrong, or indifferent. It does have pros and cons, okay? Epi is going to, in theory, increase perfusion to the heart, which it needs to do its job. But when given in large amounts, compounding with the epi that is given by your own body, so we have endogenous hormones and exogenous. Exogenous influence would be us giving that patient epinephrine, and endogenous would be that patient is in an anaerobic fight or flight mode. They are sick and their body is releasing epi and norepinephrine on its own to try to combat what is going on. And so those things coming together are going to come to a head where their effects become less effective and actually can be harmful for our patient. This is going to increase sympathetic tone, increase oxygen demand, and overall decrease the conversion rate with defibrillation. Overall, it's going to make your heart very angry and upset. And so Esmolol aims to address this, okay? It's going to help calm things down. It's going to selectively take those beta 1 receptors that epi is activating, and it's going to help dull them and block them while maintaining the alpha 1 receptor effects that, in theory, should be benefiting, our patient should be benefiting from. So that's Esmolol. We're going to be giving 0.5 milligram per kilogram, or traditionally, if you're researching this, it might be referred to as 500 micrograms, but same dose here, 0.5 milligram, 500 micrograms per kilogram IV or IO. If you guys have any questions on Esmolol, please reach out, and thank you for your time.